give people a minute to finish signing in, and then we'll get started. Welcome, everyone.
Hello, welcome everyone. Beth, you can hear me okay?
Yes, we can hear you. Okay.
And then remember to record, please.
Yes,
Thank you.
All right, since we have a good amount of people already here, let's get started. So we want to welcome you to today's webinar for MCPAP for Moms. We have a very exciting topic today, which is the postpartum psychosis, high-yield clinical cases. Today's session will be recorded and available on our MCPAP for Moms website at www.mcpapformoms.org. A copy of our PowerPoint slides will also be available on the site later today or later this week under toolkits and resources. Our presenter will stop throughout the presentation, and there'll be also time at the end to ask questions. If you have a question or a comment, please type your question into the chat, and we'll read out your question during the presentation. After today's presentation, you'll receive a brief survey following the presentation, and we appreciate your feedback to help us improve future presentations. So it is my honor to introduce today's presenter, Dr. Aruj Kamal Haider. Dr. Haider is our medical director for MCPAP for Moms and an assistant professor of psychiatry and obstetrics at UMass Memorial Chan Medical School. She is also the medical director of the Women's Mental Health Clinical Services at UMass and is a consulting psychiatrist and perinatal psychiatrist at the UMass Lifeline for Moms Network for our national perinatal psychiatry access programs. She enjoys teaching and her clinical work, and particularly interested in postpartum psychosis, OCD, and perinatal sleep concerns. So with that, I hand things over to Dr. Haider, and we hope you enjoy.
Hi, everyone. Thank you, Beth. Next slide, please. All right, so for today, we are going to first talk about MCPAP for Moms' role in supporting providers, and then we'll go into 4 high-yield clinical cases, discussing the evaluation of postpartum psychosis, and then I'll go into a little bit of the resources that we can offer our patients, families, and other colleagues. So the perinatal period is ideal for the detection and treatment of mood and anxiety disorders. So last year, ACOG, which facilitates the Alliance for Innovation in Maternity Care, AIM, re-released the Perinatal Mental Health AIM bundle, and last June released the first clinical practice guidelines, often abbreviated CPGs, for maternal health. And it included recommendations on screening, diagnosis, and treatment of mental health conditions, including postpartum psychosis and bipolar disorder and acute suicidality. And in the clinical practice guidelines, they mentioned doing a mood disorder questionnaire, an MDQ, to screen for bipolar disorder because of that rare but potential risk for postpartum psychosis, which is critical. And they also mentioned screening for bipolar disorder because giving SSRIs can inadvertently put someone into mania. Next slide, please. So this often begs the question, how can we detect or even prevent postpartum psychosis? And it's a question that a lot of our consultants at MCPAP for Moms will get when we do phone consultations, and it's a very important question. So there is no form of primary prevention for postpartum psychosis. For example, there's no vaccine. We can't just offer a statin or an aspirin before a cardiac event occurs. But what we can do is really emphasize and drive home early recognition and secondary prevention. And really what this means is empowering providers and patients to help with early disease detection or even utilize EPDS or other validated screening tools in the perinatal population to specifically target those patients who may screen positive for depression or anxiety, and then further evaluate them with a clinical assessment to identify patients at higher risk for more acute mental health conditions. So connecting them to a mental health provider early on is key. And that's where MCPAP for Moms can also play a pivotal role. And so we really want to screen as early as possible for these current mental health problems, history of psychiatric treatment, family history of mental illness, EPDS, MDQ, PHQ-9, GAD-7 are all validated screening instruments in the perinatal population. So, can you prevent postpartum psychosis? The answer is no. We cannot prevent it, but what we can do is reduce the risk of developing it, especially if there's a previous person or family psychiatric history of postpartum psychosis, bipolar disorder, schizophrenia, et cetera, even in depression and anxiety. So, we really just want to get those patients connected. So I want to empower you all that there are things that we can do to be proactive. Praveen, if we could just jump back to the slides, thanks. So while it may certainly feel like, we're kind of just sitting around, thank you, and waiting for postpartum psychosis to happen, that doesn't have to be the case. And I think having the discussion of how to reduce emotional complications as early on as possible and with family members and significant others can be helpful. And so my goal with this presentation with you all today is to delve into these 4 high-yield clinical cases and to let you know with more support you have with MCPAP for Moms, the greater the chance we all can recognize things when they begin to head downward for patients where we may potentially be concerned about postpartum psychosis. And so enhancing mental health, emotional support, psychoeducation, sleep, exercise, diet. If there is a concern for postpartum psychosis, that is a psychiatric emergency. You want to call 911. The MCPAP for Moms is not an emergency consultative service, so the patient needs to be sent to the psychiatric ER, to the ER for psychiatric evaluation, and don't leave mom alone with the baby. If there's ever a concern where you're not sure if it's postpartum psychosis, MCPAP for Moms is always here to help. Next slide, please. And so MCPAP for Moms can help provide a solution by building the capacity of perinatal care settings to provide mental health care. So MCPAP for Moms was developed 10 years ago off of the original MCPAP model, and it was developed to help navigate the perinatal mental health arena. And we provide services to any Massachusetts clinician to improve their knowledge and skills in addressing perinatal mental health and substance use disorders through 3 main mechanisms that we see here in the circles. So resource and referral, education, and perinatal psychiatry consultation, which includes phone consults and one-time assessment, which is a face-to-face evaluation with one of our 7 psychiatric consultants across the state and the patient. And so, for example, if an obstetric clinician identifies a patient who screens positive for a perinatal mood or anxiety disorder, they can then call MCPAP for Moms and speak with one of our consultants who can provide management guidance, individual indication for psychotherapy, and or arrange for a one-time consultation if indicated. And our consultants can also see the patients in these one-time assessments, after which they then provide recommendation to that patient's frontline provider to help them give direct mental health care to that patient going forward. And that provider would then prescribe or bridge prescription until a new prescriber is found. And MCPAP for Moms can help with all of that. Next slide, please. So the consultation is really the engine of MCPAP for Moms. And so since its inception 10 years ago, MCPAP for Moms has trained and enrolled almost 80% of obstetric practices in the state of Massachusetts. And we have had almost 20,000 encounters total for about 11,000 perinatal individuals in the state of Massachusetts. And what we do is we essentially are as our consultants, have made recommendations to the calling clinicians to help them treat patients through phone calls or with face-to-face with that patient, we've seen that this consultation really is the engine of MCPAP for moms. And so because of consultation and education provided, our 7 psychiatric consultants are able to indirectly assist many, many more patients than would be possible on a one-to-one basis, especially if that calling clinician can then go on and apply what the knowledge they learn from our consultants to other patients in the future. And we'll see from recent data that this is really how MCPAP for Moms works on a larger scale. Next slide, please. And so in this graph, this graph, it's the first research we have on access program impact on frontline clinical practices individually. This study was done by a UMass MD PhD student, and what it showed was that treatment trends suggest that MCPAP for Moms helps clinicians treat more complex illness over time. So the x-axis is the time. So looking at clinical encounter data of MCPAP for Moms from July 2014 to June 2020, telephone consultation, so for example, discussing indicated treatments, effectiveness, counseling pearls, is the most effective in changing provider behavior, and then the providers are able to treat more complex illness over time. And so the y-axis is the fraction of encounters that end in clinician providing treatment. And so we looked at the consultations for bipolar affective disorder, bipolar spectrum disorder, which is that blue dotted line. The black dotted line is any diagnosis. The red straight line is unipolar depressive disorder. And what you see here is with the blue dotted line, for bipolar disorder, it has gone up over time. And depression, the black dotted line, went down over time or more or less stayed the same. And so while it's not expected that frontline clinicians manage conditions like bipolar disorder, with support from our consultants, they can often initiate or continue pharmacotherapy until longer-term psychiatric treatment can be secured. And one sec, I see a question. Is the clinician consultation phone number different? Yes, it is. And we will put that number. The question is the clinician consultation phone number different from the main MCPAP line? Yes, it is. That's a good question. And we'll have the MCPAP for Moms line in one of the upcoming chats slides. Next slide, please. Patients with support see addressing perinatal bipolar disorder as an important part of their role as obstetric professionals. So one provider exposed to MCPAP for Moms said, "I'm a lot less scared to prescribe medications than I was probably 4 years ago because I see that the benefit outweighs the risk. So I won't start somebody on a bipolar medication if I think they have bipolar disorder, but if they've been on it and I call and talk to MCPAP for Moms psychiatrist and we talk through the case and they think it's appropriate, then I will happily prescribe it." So now we're going to jump into our 4 clinical cases and end with some resources for postpartum psychosis. And in these cases, next slide, please, we will discuss the role of MCPAP for Moms in navigating this complicated diagnosis of postpartum psychosis. So case number 1. So this information was left with one of our MCPAP for Moms resource and referral specialists when the OB provider called in stating, "I have a patient who is 4 weeks postpartum with a history of anxiety and unstable housing situation. The OB was very concerned about postpartum depression and psychosis due to very, very scary thoughts that the patient was expressing to her and having." Next slide, please. And so when a phone consultation was done with the obstetric provider and one of our psychiatric consultants, it was noted that the patient had a documented history of OCD. The OB noted that the patient was having thoughts about harming her baby. So that's pretty major. And she found the thoughts to be very distressing. The patient found the thoughts to be very distressing to herself, but she denied any intention whatsoever on acting on these thoughts. And the OB specifically shared what the patient told her that made her so concerned. And the patient said, I am so worried about SIDS. I'm putting my baby on his back when he sleeps to keep him safe at night, but is that really enough? I check his breathing all night long. Sometimes I even see myself flinging my baby down the stairs when I walk down with him. I would never actually do this though. So you can imagine with a patient who's postpartum how scary these thoughts can be. And the key thing is she finds them to be really distressful. And when our psychiatric consultant had talked to this OB a little bit more about these statements the patient was saying. She was saying that she was even the patient was waking up in the middle of the night repeatedly, even when the baby was sleeping, and saying, I'm walking into the nursery, putting my finger under the baby's nose to make sure that he's still breathing while he's sleeping, because she was just so afraid that the baby would, pass away from SIDS. And so you can really get a clinical sense of the amount of distress this patient was in, and didn't want to harm the baby, did not have any intention of harming the baby, I think is key. Next slide, please. And so the psychiatric consultant asked the following of the OB. What are some examples of the patient's worries or thoughts? Is the patient distressed by these thoughts? Yes, she's very distressed. She almost even expresses some shame to share these thoughts to the OB, almost embarrassed that she's having thoughts of flinging the baby down the stairs because she would never actually do that and doesn't want to do it. Does the patient appear to have insight that these thoughts are not normal? Yes, she thoroughly acknowledges that these thoughts are not normal. Any concerns about symptoms or psychosis, hallucinations, delusions, paranoia, confusion, disorganization, altruistic delusions, which I'll explain in a bit? No. So this is very much consistent with intrusive thoughts, consistent with OCD. And the OB told us that the patient had OCD. So what exactly are intrusive thoughts and how do we distinguish between that and postpartum psychosis? So intrusive thoughts are really unwanted and persistent thoughts, images, or memories that repeatedly enter a patient's mind. And the patient can find them to be very distressful, as she did in this case. And so we learn that the patient's thoughts are ego dystonic. That's the key thing with this case. And she therefore was not exhibiting signs and symptoms of postpartum psychosis. So what this MCPAP for Moms consultant did in this phone consultation was she provided education on the difference between psychosis and intrusive thoughts secondary to anxiety. These are very much intrusive thoughts secondary to anxiety, OCD, reassurance and normalization of these symptoms in patients struggling with an anxiety disorder. Intrusive thoughts are very common in OCD because they're just so anxious and they can't control these thoughts, especially in the postpartum phase. And we want to educate about how to effectively treat these symptoms and anxiety disorder. And so the management of this patient with MCPAP for Moms guidance. So the diagnosis of this is OCD. And so what our consultant talked about with the OB is she definitely needs to be on an SSRI. The OB was willing to prescribe. I'm often asked which SSRI, should I give for OCD? And this is just a clinical preference. I think all SSRIs are the evidence-based, standard for anxiety and OCD. If the patient is struggling with sleep at night and their intrusive thoughts are worse at night, Luvox is always a great option, especially if the patient has support to help with feedings in the middle of the night because it can be very sedating. So it can help patients fall asleep and rest better. I think Prozac and Lexapro are great, but I think the key thing with SSRIs and anxiety and OCD, you want to go to the higher range of dosing because that's what you really need to effectively target the anxiety and OCD symptoms. Our resource and referral specialists can help with psychotherapy options. We have a great team of resource and referral specialists that can really tailor resources and types of psychotherapy to patients' need. So cognitive behavioral therapy, exposure response prevention therapy, ERP for OCD, they can help with that. Sleep hygiene and caregiving. I think especially with intrusive thoughts, a big thing that I clinically notice with a lot of patients in my clinics is these intrusive thoughts are very exhausting. The patients find them to be so distressful, and it can really take a toll on the mind and the body when you want to engage with your baby postpartum and you have these thoughts just enter your mind. it can be very fatiguing. So we really want to support them with sleep and discuss sleep hygiene and general caregiving principles at night to make sure the parent and family and the mom are feeling well rested. So how can we max out sleep by stretching out feeds? And this could be a combination of express milk versus formula with mom's preference, or a combination of both. Sleep log can be helpful. I'll get to that in the last case. And non-psychopharmacological measures, nutrition, exercise, yoga, acupuncture. MCPAP for Moms has a lot of these resources on our provider and patient part of our website as well. Next slide, please. And so the risk of harm to baby when mother has thoughts of harming the baby. So this is just a summary of what we discussed. So when mom has thoughts, says, I have thoughts of harming my baby, what's the actual risk of harm? And so in the postpartum period, I think, and this is something our consultant discussed with the obstetric clinician in this phone consultation, up to 70% of patients experience these intrusive or unwanted thoughts due to depression, anxiety-related disorders, or a combination of these. So when assessing for risk of harm to the baby, it's very important to determine if the patients are if the thoughts are ego dystonic. Patient has insight. She finds the thoughts to be intrusive and scary, as we see on the left-hand side, the left box. There are no psychotic symptoms, and the thoughts cause her anxiety, and she's sometimes even embarrassed to share these thoughts. These are very much ego dystonic in nature, and these thoughts, the risk of harm is very low risk in this situation. Versus the right side, in ego syntonic thoughts, the patient has little to no insight. Thoughts are reassuring and less likely to cause anxiety. An example is a patient once told me, I feel like I have to harm my baby in this way to protect my baby. My baby is better off without me. That is postpartum psychosis. That is a true psychiatric emergency. Though the baby and mom are at very high risk, the patient immediately needs to go to the ER, and the baby should be put in a safe place as well. So the clinical takeaway from case one is when there are ego syntonic thoughts of harming the baby, they're often in the context of postpartum psychosis or a psychotic illness, and these thoughts need to be assessed by a psychiatric provider in an emergency setting. They are associated with a higher risk of suicide and infanticide of about 4%. Now, case number 2. So an OB calls MCPAP for Mom for a resource and referral. And in this case, we have a perinatal individual who is 9 weeks gestational age with a reported diagnosis of bipolar disorder, stop her lithium, after her outpatient psychiatrist recommended that she discontinue it. The patient's OB calls and asks MCPAP for Moms to find the patient a psychiatric provider. And I see a question, and I will get to that in a second. The patient's OB calls and asks the MCPAP for Moms to find the patient a psychiatric prescriber. So the patient was quite upset that her psychiatrist had told her to stop the medication, the lithium, when she was doing well, had been on it for so long, and started to feel worse off of the lithium. And the OB was quite concerned about this and asking for guidance and help. Is it possible, I'm just to go to the chat, question in the chat, is it possible that in the early stage of postpartum psychosis that the client may be distressed by the thoughts? It could be possible, I think. And one thing we'll see in a case coming up is the rapid clinical deterioration of postpartum psychosis and how quickly those clinical symptoms could deteriorate and worsen. So it could be possible that early on the insight is a little bit more improved, but postpartum psychosis, a key clinical feature is the waxing and waning nature of the illness and how patients can become alert and have no confusion and completely intact sensorium, and then a couple hours, even a couple of minutes later, they're completely confused and floridly psychotic. So it's that rapid clinical deterioration of the illness that's so concerning. And I think keeping an eye on that early on is key, and getting those patients connected early on is key. How can we join the MCPAP for Moms list of resources as perinatal psychiatrists? and postpartum mom support group. We will connect you with those. That's a great question. Thank you for asking. Beth and Nancy, if you could take care of that, that would be great. And I'll have a bunch of resources at the end as well. So MCPAP for Moms recommends phone consultation and face-to-face. So for this case, the MCPAP for Moms psychiatric consultant would do a phone consultation and then recommend a face-to-face evaluation with the patient. And the key thing with this is to really discuss the diagnostic assessment. It's likely bipolar disorder. If the patient's on lithium, it's probably a diagnosis of bipolar 1 disorder, but we want to discuss and confirm. And so that's what we did during the consultation, and that's what we would do in the face-to-face. Psychopharmacological recommendations. Is lithium the right medication? Should she go back on it? Does she want to go back on it? Or are we discussing an atypical antipsychotic? Potential safety concerns, psychoeducation to the provider and the patient. Can the OB bridge medications until a perinatal psychiatric prescriber is established? I think that's also key to this case because this patient's psychiatrist and this specific patient had told her to stop the lithium, and the patient wanted a new psychiatric prescriber after that, and one who felt comfortable prescribing. And so we would consult with the OB after the face-to-face and the consultation on how to prescribe that until the patient was connected with a new psychiatric prescriber. And so really the essence of this is building the capacity of obstetric and psychiatric clinicians and any calling provider really calling about any perinatal individual. Next slide, please. So bipolar disorder in pregnancy is associated with negative outcomes. And so pregnancy does not protect against mood episodes. And bipolar, like depression, is associated with low birth weight, preterm birth less than 37 weeks, small for gestational age, an increased rate of C-section. And mood elevation can lead to behaviors with known perinatal risk, and that can put mom and baby and anyone connected to mom really at risk due to behaviors like substance use, high-risk driving, hypersexuality, true manic behaviors. So the risk of untreated illness really needs to be taken into consideration. Next slide, please. So the consultant follow-up from the face-to-face. So after the face-to-face assessment, our psychiatric consultant determines the patient has bipolar affective disorder type 1 and recommends the patient going back on the lithium immediately. The patient also wanted to, she felt much better on it. How to monitor during pregnancy, psychoeducation, in discussing with patients' family members and the patient how to detect postpartum psychosis and what early signs and symptoms may look like. And I will say, I think this is so critical because oftentimes for my patients in my clinics and the patients I see in MCPAP for Moms face-to-face evaluations, family members have such a pivotal role. They are connected to, they live with, they are the patient's main and only support system sometimes who see these early signs and symptoms well before the 6-week visit with the OB or, even before they're connected with a midwife or a doula or even their psychiatrist or psychiatric prescriber. And so discussing what postpartum psychosis is with family members and who is at higher risk is so important and what that looks like. And one thing that was also discussed with this case is lithium and atypical antipsychotic transmission into the breast milk if mom chose to breastfeed after the baby was born. Next slide, please. So again, the diagnosis for this is bipolar 1 disorder. And we discussed with the OB why it's so important to prescribe lithium. Second line could also be an atypical antipsychotic like Zyprexa or Seroquel, which is olanzapine or quetiapine, in case the patient stops taking their medications or is having a hard time getting lab draws. Those are viable options as well. But also bridging the patient on the medication until she's connected with the psychiatric prescriber and discussing why exactly it's so important to do this. And so what are some of the clinical symptoms also that I am discussing with family members? Things like up to 70% of patients, perinatal individuals with bipolar affective disorder have relapsed within the first 6 months postpartum. So let's look at specific clinical symptoms. And while the onset of postpartum psychosis is the greatest, according to data 2 to 4 weeks, really we can see it at any time. That's the highest risk window. But I had a patient really who started developing early symptoms of postpartum psychosis in my outpatient clinic because her baby had just turned 1 year old, but her toddler was going through the dreaded 2 year old sleep regression. And she started to become psychotic. She had a history of bipolar disorder. And so it can happen at any time, I will say. And so the highest risk is obviously, 1 month postpartum when sleep deprivation is intense. But I think also discussing that with family members is important. And other clinical symptoms we see, cognitive symptoms like poor concentration, confusion, disorientation. Behaviorally, they may be agitated, they may be very hyperactive, their speech may be rambling, their mood can be very, elated or labile or even very sad. So, any combination of those, and I think discussing that with family is important. And so I see lots of questions about resources, which is great. So resources to provider and or outreach to a patient with lists of psychiatrists, therapists, PSI support groups, group psychotherapy support groups, peer support groups, any and all. Our resource and referral specialists at MCPAP for Moms have such a critical role here and really enjoy interacting with providers and patients and getting them, the resources that they're looking for. Sleep hygiene and caregiving. I really do believe with any diagnosis of bipolar disorder in the perinatal time period, you have to have a discussion on sleep hygiene and caregiving and discuss what that actually looks like, especially third trimester to postpartum. It's so important how to maximize sleep even before the baby is born. So mom is feeling as well rested as possible during delivery and postpartum, stretching out feeds, sleep log and all that. And red flag symptoms for developing postpartum psychosis. Again, like I had mentioned earlier, really engaging the patient's family and significant others in this discussion. Next slide, please. Let me just take a quick look at the chat. Great, thank you, Beth. Do you recommend scheduling a 2-week postpartum visit with provider for those with? Absolutely. I think that's a great question, Jennifer. So the question is, do you recommend scheduling a 2-week postpartum visit with provider for those with the diagnosis of bipolar disorder? 2 week or even 1 week if you are able to. Especially if they are on medications, and especially if not on medications, I would want them to be on it as early as possible. But as early as you can get that patient into your schedule and check in on them, make sure the medication is okay, the dosage. If you have any questions about that, MCPAP for Moms can help with a phone consultation, but absolutely, it's a great consideration. Okay, just making sure. How often do you see psychosis developing during pregnancy rather than postpartum? So I think the highest risk is certainly postpartum. The exact percentages, I don't know. I can speak to my clinical experience, but I do think it's significantly more in the postpartum period because of the sleep deprivation, the sudden sleep deprivation, and the sudden withdrawal of hormones in the postpartum period that tend to make more perinatal individuals more susceptible to experiencing psychosis compared to others. And especially, I think those who have a previous psychiatric history or previous family psychiatric history of some sort are at even higher risk. So I think the delicate thing about postpartum, which makes us see it more in the postpartum period, it's sleep deprivation. You're not getting through REM and non-REM cycles, those 90-minute cycles regularly because parents are up feeding the baby, and the sudden withdrawal of hormones, all of that really plays a factor. I think if someone had a pre-existing diagnosis of a psychiatric diagnosis and was not on medications, they're at higher risk of some sort of perinatal psychosis, I think obviously they could be at high risk for relapse during pregnancy as well. It's a great question. Okay, so case number 3, a primary care nurse practitioner requests a phone consultation. A 35-week perinatal individual presents with auditory hallucinations in the context of poor sleep from increased urination and physical discomfort due to pregnancy. Next slide, please. The face-to-face is also recommended. Now, during the phone consultation that was completed, what was discussed was guidance around safety planning, discussing trauma history, and auditory hallucinations directly related to trauma. So I think that's very important, because in this specific case, the patient um, reported to her provider that she was hearing voices. And she also made it very clear is that I've had these voices before, and they're very much directly related to trauma, predominantly at night when those triggers come out. And they're voices that I'm used to, they're not new. And I need some extra help getting through this. This has happened before. So that was made clear and confirmed during the face-to-face. And so during the consultation, the patient was deemed safe, and the provider, most importantly, felt like the patient was very safe, and felt comfortable navigating with help from MCPAP for moms. And so a face-to-face evaluation was recommended. And what we would do is really focus on the diagnostic assessment for pregnancy-related insomnia, psychosis, OCD, or PTSD. Really, it was, the suspicion was this was some sort of complex PTSD, but just making sure that a full, diagnostic differential was discussed. Is the face-to-face evaluation over the computer or in office? Both. We have the option to see patients in person and via telehealth. It's a great question. Thanks for asking. So after the face-to-face, the psychiatric consultant determines that the patient has chronic complex PTSD and discusses an atypical antipsychotic and an SSRI with the patient and provides psychoeducation. This patient had already been on a very low dose of an atypical antipsychotic. It was risperidone. And so the consultant and the patient and the healthcare provider, we discussed increasing the risperidone above 0.25 to really help kind of treat the worsening auditory hallucinations, and also potentially an SSRI to treat the main symptoms of PTSD and the nightmares and the flashbacks. So a birth plan, sleep plan, adopting a trauma-informed care approach is key. And keeping in mind that, trauma is a very pervasive experience, and we're always happy to offer trainings on this as well. And we incorporate it in all our phone consultations with calling providers and our patients. But trauma-informed care should really be applied universally, I think, in all healthcare settings, to create that environment that promotes recovery and safety and avoid this inadvertent re-traumatization. So, and one thing the psychiatric consultants at MCPAP for Moms and program-wide, we discuss, it's really when looking at a true trauma-informed care approach, it's shifting that paradigm from what's wrong with you to what happened to you and how does it affect you today, and let's talk about it. And we also encourage the patient to remain on her meds during and after delivery, and encourage the calling provider to discuss the plan with family members as well. Next slide, please. And so I like this slide. Feel free to take a screenshot, but it really just looks at trauma, how it can be experienced at so many different levels, at the individual, the interpersonal, and collective level. And there's so many different factors that go into it: social and behavioral, determinants of health, political and economic trauma, war and combat, community violence, and so forth. So there's a lot of different intersections involved. Next slide, please. So the management for this is, so the diagnosis was complex PTSD. And I will say, for complex PTSD, just to share a clinical pearl that I think can be challenging to distinguish from this and postpartum psychosis, is when while hearing voices are associated with psychosis, in the context of dissociation, it usually can arise from internal experiences related to the trauma rather than hallucinations disconnected from reality, where you would really find in perinatal psychosis. So this was not postpartum psychosis. This was very much trauma related. But again, we would not expect anyone to know that. MCPAP for Moms is happy to discuss that at any point of the way, a consultation, a face-to-face. That would really need assistance or discussion with a psychiatric consultant. We would not expect anyone to know that. So after the face-to-face assessment, the nurse practitioner was willing to prescribe the meds, and our resource and referral specialist helped the patient find a therapist and a long-term psychiatric prescriber, while the nurse practitioner bridged the medication, continued to prescribe the risperidone and the SSRI. I will say other options, especially if there are symptoms concerning at night, or antihistamines, alpha-2 adrenergic agonists. Prazosin could be a great medication for nightmares and flashbacks at night, but we won't go too much into detail of that. We're always happy to talk about that in a training or a consultation. Adverse childhood experience screening, if the provider has the time and resources to do so. And our research and referral specialists helped with therapy, finding therapists who were well-informed in trauma-informed care. And sometimes EMDR can help with that, and we can help with that too. Especially if there's a diagnosis of PTSD. Next slide, please. Okay, so we are on our last case, and then we'll jump into resources and leave it open for some questions. So in this case, this was a 1-week postpartum perinatal individual with a history of bipolar disorder, limited. Oh, sorry, I missed a question here. Does the face-to-face include the provider, or does the patient meet with MCPAP individually? The MCPAP for Moms face-to-face assessments are with one of our 7 psychiatric consultants and the patient. The assessments are not with the resource and referral specialist. They are not with the calling provider. They're not with the person who called or requested the face-to-face assessment. I will say the face-to-face assessment for MCPAP for Moms, we can only do those if we know who is prescribing, because after face-to-face assessments, they're often to discuss diagnostic assessment, medication recommendations, psychotherapy recommendations. A lot of education is given during that. And so if a patient needs to be on a medication after a face-to-face assessment with our psychiatric consultant and the patient, we need to know someone is going to prescribe, because MCPAP for Moms, we don't prescribe as a program. We can connect them to a psychiatric prescriber after the assessment, but we would need to make sure that the prescriber calling in the face-to-face assessment is willing to prescribe before we do that evaluation. And then afterwards, our resource and referral specialists can help with anything related to resources and whatnot. That's a great question. So case number 4, a 1-week postpartum perinatal individual with a history of bipolar disorder, limited psychosocial support, anxiously calls her family medicine physician asking for a sleep aid because she has barely slept since delivery. So I think the key things here, she just gave birth, she's a week postpartum, she has a history of bipolar disorder and not a lot of psychosocial support, and she's calling her healthcare provider asking for help me sleep, help me sleep. So when I hear about this clinically, I'm thinking, why is she not sleeping? What is going on? Is she sleeping when the baby is sleeping? For anyone in my clinic who tells me, my baby's sleeping through the night, but I'm not, I'm immediately like, that's a clinical red flag. If your baby is sleeping and you're not, what are you doing? Why are you not sleeping? Why are you not resting at night or napping when the baby is napping? Why are you not getting that rest? So let's probe into that and talk about that a little bit more. So this patient is asking for a sleep aid. It sounds like she's really asking for help to sleep. So what's going on at home? So next slide. So the MCPAP for Moms psychiatric consultant would do a consultation and then recommend a face-to-face evaluation with the patient. And this is high risk. This patient is high risk given a history of bipolar disorder. And after face-to-face evaluation, the patient is deemed safe. She is not floridly psychotic, but she needs assistance with more sleep, and she is open to increasing her risperidone. So how can we support those with a history of bipolar disorder in the postpartum period and those with limited psychosocial support? So in this situation, the MCPAP for Moms consultant um, saw the patient and said, no, she is not floridly psychotic, but she was on risperidone for her bipolar disorder. It was not enough. She was very exhausted postpartum. It may not have been at an effective dose, and she really just needed a bump up to help her sleep. Risperidone can be sedating at night for some patients. And she wanted to take it knowing that it may make her a little bit more drowsy, but she had limited support at home. So I think the key thing with this case is how can we support those with a history of bipolar disorder or any complicated illness in the postpartum period, and they don't have, a spouse or a loved one or anyone who can really help them at home. And that's always really challenging. And I think a lot of that comes down to resources and what the patient is able to what the patient is willing to kind of be flexible on, and what the patient's preferences are that she or he feel really strongly on, and whether a spouse is involved or not, and are they open to bottle feeding? Are they open to having someone, a family member or a neighbor give the baby a bottle of express milk or formula? I think taking into consideration all these different preferences and the risk, balancing it with the risk of untreated illness, with a small risk of certain medications, is always a challenging but important conversation to have. And so to get into that a little bit further, next slide, please. One thing that we can, so for this case, this was a diagnosis of bipolar 1 disorder. A face-to-face evaluation was done. Yes, psychopharmacologically, lithium or atypical antipsychotic. The patient was already on her risperidone. We bumped that up. Red flag symptoms for developing postpartum psychosis were obviously discussed with the patient and a healthcare provider. And how do we improve sleep, and how do we maximize that sleep? Next slide, please. And so what we do know with bipolar disorder is up to 40 to 50% of perinatal individual experience a relapse or an exacerbation of symptoms during pregnancy, and up to 70% of women with bipolar disorder relapse within the first 6 months postpartum. Now, one thing that we can discuss, and this is not something that's on MCPAP for Mom's website, this is something I just plucked from the internet and I'll sometimes discuss with patients in my clinics, is how to discuss a sleep log or maximizing hours of sleep during the day and at night with patients. And especially, like I mentioned earlier, sleep is so important and so critical in the postpartum period. How can we maximize naps during the day so that the parent can sleep at night? And this can come in handy when parents have less support at night, or it's a single mother with a newborn baby or multiple children at home. But looking at the entire sleep schedule for the newborn and how this impacts the parent on a 24/7 schedule, I think is one way to approach the discussion with families with limited support. So really maximizing naps during the day so that baby is hopefully sleeping more at night, and therefore mom is sleeping more at night, is one potential option, though still very challenging. Next slide, please. Okay. And so I think another, to close out case 4, where we increase the risperidone for the patient, there was a diagnosis of bipolar disorder. We discuss if symptoms worsen, there are resources that we can offer you or a family member in situations like that. And so for that patient, she was able to get the assistance of a neighbor to help her with the baby at night. But also what was discussed with the patient and her friends and neighbors that were helping was, what do I do if there is a true psychiatric emergency, and if symptoms do develop and it's in the middle of the night when I'm not sleeping, and MCPAP for Moms is not available. If the patient becomes floridly psychotic, they should call 911. Anyone can call 911, the Massachusetts Behavioral Health Helpline crisis for that patient. And I think the key thing is it's really it's it's looking at the situation immediately, but also how can we connect family members or anyone connected to that patient to resources as well. And so the Massachusetts Behavioral Health Helpline is also an option. And I include that in here because anyone can call, including family members, on behalf of a patient. So anyone can call, text, or chat 833-773-2445. It's open 24/7, 365 days a year, and it's free. And it is staffed by trained clinicians who will stay online with you until you get the support that you need. It also connects our patients to crisis support or community behavioral health centers, which are essentially CBHCs. And CBHCs, I think of them as a one-stop shop for a wide range of mental health and substance use services and treatment for perinatal and non-perinatal individuals. There are almost about 30 in the state, and they essentially offer immediate confidential care for mental health and substance use needs. And I think the Massachusetts Behavioral Health Helpline can connect family members calling on behalf of patients and our patients to the CBHCs 7 days a week and beyond the hours of MCPAP for Mom. So it's a really, really great option. And I think apart from that resource that we can offer to patients and family members, there's also the discussion of imminent risk versus non-imminent risk. And I think that if there's any concern about that, a calling provider can call MCPAP for Moms at any point. We don't expect you to know. We can talk to you. Does a section even need to be done? How do I do a section? We can guide you. And I think obviously if it's true suicide or postpartum psychosis concern, we never want to leave mom alone with the baby and call 911. That's a psychiatric emergency. Next slide, please. Now, in terms of specific postpartum psychosis resources, so PSI, this is a screenshot directly from the perinatal psychosis tab on PSI, postpartumsupport.net. It's a great, great resource. MCPAP for Moms has this resource on their website. The PSI has virtual support groups, specialized support coordinators, and an extensive list of resources like books and podcasts and interviews and journal articles on this tab. So I encourage everyone to look at this if they're able to. And patients can join these support groups virtually, anonymously, and it's a great resource that we advocate at MCPAP for Moms for as well. Next slide, please. Now, these are vetted resources from MCPAP for Moms. MCPAPformoms.org has a lot of provider and patient-facing handouts and brochures. ACOG, MGH Center for Women's Mental Health, womensmentalhealth.org, Reprotox, PSI, postpartum.net, LACMed, and Lifeline for Moms has some provider and patient resources as well. And there's always the Massachusetts Behavioral Health Helpline that I had referred to earlier. Thank you, Beth. For sleep hygiene and other handouts on the MCPAP for Moms website, there's a handout to help start that conversation about sleep hygiene. Yes. And the link Beth has put in the chat. And next slide, please. Great. Okay. So I think that's it. And does anyone have any questions? And let me just go through the chat quickly to make sure I didn't miss anything. For non-prescribers, we're happy to talk to you and point you to a variety of websites, databases where therapists, prescribers, helplines, and support groups can be found. Lists can often be changed and get outdated. Many of these are on the MCPAP for Moms website in the Birthing Family tab on our site. Yes, so that will be a full list of resources for non-prescribers as well. Thank you, Beth. And of course, MCPAP for Moms number 855-666-6272. And I will say, I'm getting a message about the resources specifically that MCPAP for Moms can offer for patients. Yes, so our team of resource and referral specialists will will tailor the resources specifically to patients' needs. We can send these resources to patients directly through patient contact or send these resources directly to the provider. And this includes many different things. Does the patient have a specific language preference? Hybrid, does the patient want in person, or does the patient want, a virtual therapist only? What is the patient's insurance? Does their specific plan, take this therapist or psychiatric prescriber? To the best of our ability, we'll answer that. Are there bipolar disorder support groups? Are there, postpartum psychosis support groups? And so our resource and referral specialists will really try our best to tailor this to the patient's need. We have a wonderful team who really enjoys interacting with our providers and patients on that. And that can be sent to patient or provider. I find the waxing and waning of postpartum psychosis to be unsettling for fears of missing it, since we only see clients for 50 minutes. Absolutely. Is this where the importance of education family members comes in? I think that is such a critical question and perfect opportunity to, yes, educate family members, especially if the patient is at high risk, or there are concerns for the patient being high risk. So for example, say a validated screening instrument was done, EPDS, MDQ, the CITI-3, GAD-7, PCPTSD, and um, you know, there are concerns that they're positive, but also based on the patient's clinical presentation, or they have a pre-existing personal or family psychiatric diagnosis of something like bipolar disorder or psychosis or schizophrenia, or even severe anxiety, perinatal anxiety or depression. There is recent data that, sometimes severe anxiety can be related to postpartum psychosis as well. It doesn't always have to be bipolar disorder. 70% of the time, the data that we do know shows that postpartum psychosis occurs in the context of bipolar disorder. But clinically, I will say that's not necessarily always the case. But I think the key thing is, and I think that's a great question, Kimberly, is getting those patients connected to mental health treatment or connected to a mental health provider or any healthcare provider as early on when when there's concern for anything related to postpartum psychosis or a complicated diagnosis, and educating and kind of discuss bringing in the villages early on is so important, because like I had mentioned, family members are the first to see the early signs and symptoms of complicated diagnosis, including postpartum psychosis. The waxing and waning nature can certainly be concerning, but I also think it's an opportunity for us all as healthcare providers to get our patients connected to treatment as early on. And MCPAP for Moms is here to support you, and and hold your hand, and we don't want anyone to have to go through that alone if we can avoid it. What do you think about mirtazapine for sleep pregnancy too? There is some data on mirtazapine. It can certainly help with sleep. I think the key thing with any medication that causes a patient to be drowsy is, do they have the support at night to take care of the baby in case they're having challenges getting up in the middle of the night to feed the baby? So I think that having the discussion of, the risk of untreated depression or anxiety if you're considering mirtazapine, versus the risk of the actual medication in itself is an important discussion. Yeah, so that's what I would say. It would be wonderful if MCPAP sent the referring provider the same resources that were sent to the mom. Sometimes it gets lost in their email, resulting in delay in treatment. This would allow the provider to follow through with the mom. That is great feedback. Thank you for saying that. And we do send resources to provider and patient. So if there's a concern with that, yes, I agree. Sometimes it can get lost in the email. We would want to know about that. But this would allow the provider to follow through with mom. Absolutely. A resource referral specialist can and do both of that. All right. So it looks like we have 1 minute left. I will put my email in the chat. Thank you all for attending. And if you have any questions, please feel free to email me or us or anyone at MCPAP for Moms. Oh, thank you, Beth. Sorry. Or email mcpap@carillon.com. So I will just answer your question quickly. Jessica, you mentioned Luvox for anxiety with sleep benefits. Would that be contraindicated with breastfeeding? SSRIs, there's a very strong evidence base for all fluvoxamine is what Jessica's referring to for all SSRIs in pregnancy and postpartum. There are no contraindications according to the evidence. And we know that SSRIs, there's a very low transmission of them into the breast milk. And you really want to, weigh the risks of the patient not sleeping and untreated anxiety or OCD or depression, with the minimal risks of SSRIs that we know of. And happy to answer more questions about that. Yes, mcpap@carillon.com to get connected to all our other trainings. And we will have an upcoming training in SUD in the perinatal population over the summer. So look forward to seeing everyone there. Thank you so much.